expectations from the lab?
Good afternoon, everyone, and thank you organizers for asking me to present this topic to this audience. And the topic that was given to me was my needs and expectations from the lab. I have specifically put as microbiology lab because I'm an infectious disease consultant. So it's only right that I speak about microbiology lab because I know what my expectations are. So. My disclosures are, I believe that diagnostics is a very powerful tool. It empowers clinicians to make treatment decisions. And I also know that the needs and expectations from a microbiologist towards a clinician is much more than the reverse. So these are all true. But just to go forward with this talk, I'll be more focusing on what as a clinician, especially the ID physician, expect from the lab. I know that most of it you all know and it's being followed, but still probably there are some points that you would like to understand from us and then take it forward. So I have broadly divided into two. From an infectious disease specialist, what do you expect? From infection control, antimicrobial stewardship, and the quality, what do you expect? And to start with, as an ID physician, I would like my lab to be systematic, error-free, include newer relevant tests with a fast turnaround time, communication, bench to bedside, and of course research. From the IC perspective as well as quality perspective, I would like inputs and improve upon sampling, training, cascade reporting, antibiogram or cumulative antibiotics susceptibility report, outbreak reduction, resistant trends, and hospital epidemiology. So, don't skip basic tests. We all know that no pathologist will report a pathology report without, biopsy histopathology report for bone marrow without a peripheral smear. So, I have seen, maybe it's not the practice anymore. Many hospitals or accredited labs don't do this. They do a gram stain before they report a culture. But still there are, a lot of labs which just go ahead and report on culture. You cannot report a culture without a gram stain, even if they don't ask for. So gram stain that needs immediate reporting, you all know. The CSF, the most important thing, and several other reports, critical specimens, you know better than me. I would suggest you please create an algorithm so that you don't do unwanted tests. The best algorithm and the liaison you can have is with the biochemistry lab. Don't report urine culture without a dipstick, which is very easy. It is a must before any urine culture. Liaise with the biochemistry lab not only to reduce unwanted tests but to reduce antibiotic use, because any culture which grows any organism has to be treated for a clinician, most of the clinician. But you know that many of them can be colonizers or even contamination. Again, for C. difficile infection, we all know in Western countries there is an algorithm which we don't have because probably we don't see much often. But that testing should be based on an algorithm. Whether the patient is on laxative, whether the patient is symptomatic, whether he has leukocytosis, stool has some pus cells or whatever, there should be an algorithm, and then you go ahead. Otherwise, you will be asking for trouble, more tests, more results, and more treatment. Error-free. Yeah, this is very, very important. This needs expertise. When I tell, Dr. Anil will tell that you should have a lab first, you have an expertise. I know. But still, if you have a lab, please have good technicians. They should be very, very good at gram stain. We have had instances of gram stain, GNB report as GPC. We can understand if it is a coccobacilli, it can happen. But in the night especially, you should have a trained technician, because the antibiotic charts are based on the gram stain, especially in the blood. AFB stain, it cannot miss an AFB. So you need trained technical staff. Please try to retain them if they are unhappy, I should say, because that matters to the lab. An organism that is, this is for the microbiologists. I know you're all specialists, organisms, whether you know whether to culture further and report further based on the pure or mixed culture. Species identification in this day and age is very, very important, especially with Candida auris coming up, and reporting the susceptibility. You know, with carbapenem resistance, clinician depends more on you microbiologists to know what are the susceptibility pattern and how to go further to test the resistance pattern and for the second line and third line agents. So for this, you need expertise as well as you have to be updated. New relevant diagnostics. I put as relevant diagnostics because not all the new diagnostics should be used. And this is an era of PCR. You cannot get away with that, and COVID-19 has made everyone who have at least underwent a PCR, and even layman knows PCR, and I think second most commonly used word the last 2 years. But remember, these tests are expensive. They should be a boon, not bane to the patient. So you have to choose the patient appropriately to have the real benefit. And there's a wonderful document I would suggest everyone should read. Both clinicians and the microbiologists. It's an IDSA document that is released on 2018, how to best use your lab. It is based on clinical syndromes as well as the pathogens and what is the tests that are currently available, and these are actually relevant tests, and it is not it also includes serology. It's a beautiful document that I suggest that every one of you please go through. Coming to newer diagnostic relevant tests that I would expect my lab to have. If they don't have in-house, they should have liaise with some other lab and get it done, because this matters to the patient and make treatment decisions on this based on this. And one important thing, the multiplex PCR for infectious disease syndrome. So this is very, very beautiful thing, because you have infectious disease, you think about 5-6 pathogens at a time. You don't want to run each test separately. So multiplex PCR definitely helps us. And the one thing that we have currently in India is the film array panels. I will talk about it in a couple of slides later. We should also have some panels like this for endemic viruses. Should be like for meningitis syndrome. You know, film array is for Western. We don't have for JC, dengue. So you should have a panel for that. In one go, you should have results. So in that clinical syndrome, if a patient comes with meningoencephalitis, you only by doing the relevant test and picking up, you will make the first diagnosis. Similarly for hemorrhagic fevers. Independent PCR can be run for CMV, JC, BK, PCP. These are all relevant if you have a transplant program in-house. You should not run a transplant program. I should say, you should not be given permission to run a transplant program if you don't have access to this test, even if not in-house, with a fast turnaround time, because this matters patient treatment decision. Resistant gene testing is, if you can't afford a multiplex PCR which includes resistant genes, this can be a cheaper one where you can run this test and you have a very good turnaround time in 2 hours, Kavar, Mecke and Vanni. These are independently available too. Malditov is for current identification of certain candida, especially, and certain non-lactose fermented. You may need this. It is currently used on isolates grown in cultures. But then we are expecting direct MALDI, which is awaiting FDA approval. I think it should be a game changer. If you have the machine, it's very cheap, and direct MALDI will be a test to look out for future. 16S rRNA, whole genome sequencing and next gen sequencing, all we would want, but not in all cases. We would like to have it for those samples where the yield is low. You know, valve, prosthetic joint, ophthalmic fluid, everything. But these are cases which we see day in and day out. I don't want it in-house, but please have a liaison with a lab with a good turnaround. It is possible. Certain labs do in volumes because they get so many samples. You just have to liaise, sign a MOU, get the clinician what he wants. That's it. Serology, there are a huge number, but clinically what is relevant for us is beta-glucan, galactomannan, histoplasma antigen, regional antigen, and parasitic serology if you find more common in your center. So any test, all the new tests that I have said, most of them are with a very good turnaround time, and so it is called rapid diagnostic test. Accumulating samples and running the test is not the thing that we want in ID, infectious disease, you know. It can happen in pathology or any other department, but not in ID, because valuable time is lost. So that means empiricism will continue. So liaise with the lab with a fast start. That is the most important thing. With at least they should definitely ensure the quality. And please procure whatever point of care testing that is feasible and that is cheap also, like dengue antigen, rapid strep antigen, which will reduce the antibiotic use in the outpatient department, rapid malaria card test, and lateral flow from cryptococcal antigen. We'll just talk about this Guillain-Barré syndromic panels because we have had 5 to 6 years of experience. It's a wonderful test if you apply in the right patient. It eliminates guesswork, resistant genes identified with the current panels, and short turnaround time, and you are enabling the clinician to have a very targeted therapy in hours. So there are, initially we had 4 panels, now we have BC2 as well as a pneumonia panel, and the respiratory pathogen panel has been expanded. It's a very wonderful panel except for good patient selection to maintain that so that you pass the benefit of the cause to the patient. So if you all know, this is a standard method, blood culture flags in 24 hours, you do a gram stain, it shows GPC, and then what do? You do the plate it, and 24 to 48 hours it grows, and another 8 to 16 hours it takes for the ID and the DST. So overall it is 72 to 80 hours from the prick, okay? So with the BC2, what you see is it targets 43 targets, turnaround time is 2 hours, and which are very good sensitivity and specificity. I can assure you because we have matched the samples with the culture, and we have, to my surprise, it has picked up Candida, it had picked up 2 pathogens, and we were able to even de-escalate. We find that it is CTXM, not CRE. And the most important thing is detects Candida auris. What more do you want? You wait, culture grows Candida, you send to MALDI to identify because Vita cannot identify. You lose 5 days, infection control practice is gone for a task, treatment is also gone. So this is a very, very beautiful test. If you have flag, if the patient is critical, in transplant, in ICU, multiple antibiotic exposure, please avail this test. And recently, last 2 years, we have the advantage of it diagnosing OXA48 and NDM. So it's a wonderful test. So we published this paper in 2016. This is based on the previous panel when we didn't have the KPC, we didn't have the NDM or the OXA. Still, at that point in time, we found the turnaround time was 2 hours as compared to 2 days for the conventional method, and we were able to make some decision, either escalation or de-escalation in 47.2% based on this. But then remember, if you have this test, that alone is not sufficient. There should be someone who can act on the test. So this test works best if you have an ASP, that is antibiotic stewardship program, and a person who runs that. It can be a clinician, it can be an ID physician, anybody. But somebody has to react the test, make the change in the antibiotic within 1 hour after releasing the test. Then the cost invested on the test is balanced by the antibiotic regime that you choose. You may de-escalate, you may cut down the antibiotics, and then you make the cost benefit. Respiratory panel is again a beautiful test. In the recent last 2 years, they have included SARS-CoV-2 as well as the MERS, and atypical organism. That's a very, very important, interesting aspect. That is pertussis, chlamydia, and mycoplasma is included, which will never grow. And in pneumonia panel, they have included Legionella, which is a very, very important pathogen which will push the patient to ICU. The sensitivity and specificity is very good if you select the patient right and the sampling technique is correct. So this is our data which we presented 2 years ago, that is pre-COVID. So our data was between 2017 and 18, where we had analyzed 217 adults and 66.4% were viral pathogen. So that is the most common community-acquired pneumonia, I should say. Influenza was most common, 32% were influenza, and the most important message that we got from this is seasonality. Flu seasonality we were able to see, and we were able to even time the vaccine in our area. It may be different for different centers, but this is a very good information. So it's not only helps in treatment, there's several other aspects with the data that you can look at and change your therapy as well as vaccination. Again, we looked at the Guillain-Barré meningoencephalitis panel. Our yield was 26% with this, and as compared to 3% for culture. And the majority were due to enterovirus, and it again has seasonality during the winters. In US, it is reported during summers, but we found that it is more common in pediatric, and in 2 subsequent years, we found it is more common in the winter. So it all gives so much of information, and look at the de-escalation was much more common in the Guillain-Barré group than conventional group, because when the clinician suspects virus and see that virus, then he has the courage to de-escalate, not otherwise. This again GI pathogen panel. So we found that 6% is a stool culture yield as compared to 32% multiplex PCR by multiplex PCR, and salmonella was the commonest. So everyone can ask, why do you do a stool routine, stool film array for salmonella? We did for these patients, either they are in acutely ill. So you should have an algorithm whom you test. Acutely ill, critically ill patient, or only chronic diarrhea. They should be not otherwise. If the patient is stable, please don't run. Even in acute patient, we found salmonella as common. Probably these are non-bipolar salmonella, but still we were able to have the courage to de-escalate after seeing this report. So it matters. So coming to the fifth point, that is communication, I have put it two way because patient details you should get through the request form. It could be electronic or checkbox, and critical value should be communicated to the clinician on real time. It can be culture, CSF, AB, C. diff, MDRO, anything which matters. CRE guidance should be given by the microbiologist to the clinician for further testing and therapy in this day and age, because it's very, very difficult to formulate a therapy in such a critically ill patient. And when a clinical relevance of sample is in doubt, please go have a chance to go through a record. If the specimen is poor quality, it should be rejected. Call physician to clarify and resolve the problems when you have some difficulty in specimen submission, because after all it is their patient, their specimen, they will definitely listen. Bench to bedside, this is what I would like to see your clinical rounds, understand the factors that determine the treatment. It is not a culture report. You may have a pan-sensitive bug, but the patient will be in septic shock. So there may be some bioburden effect that we will be seeing, so clinician will not have the guts to de-escalate. So understand these clinical problems only by going for rounds. Prioritize and process a specimen if it comes from operation room or interventional radiology, because these are very, very precious specimen. You have to process immediately for the maximum benefit. Understand the infection control practices. This is again advantage if you go for rounds. If you can spread half an hour to 1 hour of rounds per day, depending on your time, I think you will make a lot of change among the physicians. Not a new, but among the physicians, because you will familiarize and build trust among your colleagues. Research, I would like, because you are sitting in a treasure of data, so you can do a lot, I should say, than clinicians. You can have whatever you want, you can choose an organism and store it and do whenever you want to do a research on, unlike clinicians. Serotyping, molecular diagnostic, hospital epidemiology, resistance trends, these are all a lot of scope for research. And way back, Robert Koch has put this, pure culture is a foundation for all research in ID. So coming to a few points on IC, AMSP and QI, what all you can do. Definitely you can improve a lot on what you receive, sampling, pre-analytical. So the sample quality, you may receive all junks, but then you have to look at how to improve, because that depends on what goes out. Look at appropriate site timing and volume, whether it reaches. And also look at turnaround time of the sample that reaches the layer, because we don't know how many hours it is lying around without, if need be, without cold chain and then reaching a lab. Proper storage if delay is expected, and labeling such as wound is not helpful, you all know. So specify site and clinical is very, very important. So there should be an electronic thing where your submission is not processed unless these are all filled up. This is mandatory. So you should have the courage to build that system so that your reporting is very, very good. It will be helpful. For this, what you need is training. Training reduces background noise. Training for sampling, link with nursing quality so that nurses are trained, because they take the maximum samples. Second is residents, nobody else. So focus on that group. Audit and give feedback. So over a period of time, if you do your audit and feedback, the system will improve. Not just by just bringing a case, no. Blood and urine culture, aseptic technique is linked with contamination rate, you all know, and the contamination rate is linked with antibiotic use. So specimens should be collected prior to administration of antibiotic. That should be also a protocol. Only by training and audit and feedback, the system will improve. Pus fluid tissue biopsies are preferred, you all know, than wax. Drain samples usually reflect colonization. So your report should go with a tag that these are drain sample, this is likely colonization, so let them take a decision. Specimens like sputum, sinus, wound, fistula, please, you have to train the surgeons. When they are in, if you have a residency program, please have a class, induction class. That's very, very important, because most of the commensal microbiota is in all this. So So unless they take appropriate collection, they will contaminate the sample and they will complicate the interpretation, just results in antibiotic use. So don't accept swabs except naso and oropharyngeal swabs. Swab is not a specimen. Swab just picks up extraneous microbes. It holds very small volumes. Difficult to get bacteria, fungi out of the swabs into the culture plate, and it grows rarely. So I would discourage that the swabs. I would encourage the microbiologist refuses swabs except for naso and oropharyngeal. So you have to train your surgeons from where you get the maximum swabs. Reporting, don't report all that grows. There should be cascade or selective reporting. Do not report carbapenem susceptibility when a pathogen is susceptible to narrow spectrum. Therapy related comments is very, very important. You know that Citrobacter fluoride is susceptible in vitro. Even if it is susceptible to cefotaxime, ceftriaxone, it may fail clinically. Give that note to the clinician. They'll be happy. Supplementary testing for susceptibility of new drugs in MDR is very, very important. Repeat testing if you find that the resistant and susceptible bacteria doesn't match. Like if you find a VRSA which is not reported in your unit for long, retest or send for a QC somewhere. Add additional comments if you suspect colonization and contaminants. This is very important, as you all know. Cumulative antibiotics, antimicrobial susceptibility report. Biannually or at least annually. You can use HUNET and help formulate empiric therapy. You should be the first one to recognize an outbreak or a cluster. You should not be a clinician. Quickly formulate a team and proceed, investigate, and please do multiply. This is what we published a year ago. It was an Acromegalis bacteremia outbreak that occurred in a hospital due to furosemide sample contamination. But it was found by when we went for rounds. In a week, we had 3 consults for Acromegacter. But then I told Micro, no, I should not be the first one to get it. We should be alerting us, because we lost 1 week. Resistant trends. So resistant trends can be done in critical areas. You can choose your location to begin with. You can correlate with antibiotic utilization rates, and you can look at the IC measures and bring on change. It's a feedback. So you can connect the antibiotic use with resistance and the infection control measures, and then give them an update feedback. It can be by mail. It will make a lot of change in your practice. Hospital epidemiology is something you can all look forward to. It is widely done. It is a speciality in Western countries which we don't have here. Surveillance is a cornerstone for that. Early warning system using electronic alerts. And go ahead with typing and fingerprinting for all the epidemiological related issues. It may be anything. It can be an outbreak, it can be a B patient that's bothering you, it can be a ORS that's bothering you. You learn a lot, whether it is a point source or what. And finally, few slides on crosstalk. You please call the clinician if you don't have an adequate clinical information. Alert them in real time for all the critical signals. Call the nursing training quality if your blood contaminants are increasing or a blood culture volume is low, because then the output is very bad. You call the HAC admit if you suspect an outbreak. These are all at least is expected. So clinical microbiology seems at a crossroads. The downside is the clinical futility of traditional measures and the cost-cutting pressures is a downside. So what happens is, with this, we are outsourcing to off-site commercial or centralized lab. So increasing isolation of the clinical colleagues and concerning to increasingly technical roles. But the brighter side is it boosts the clinical relevance. We expect us in conventional and the innovative rapid diagnostic tests still needed. Communication and bench to bedside will again push you to more popularity and most wanted person. And actually, I am seeing levels unseen since the time of Robert Coe and Master. So these are just a roadmap. You can choose whatever is feasible for you. If you have a patient and arriving in your hospital, the clinician should be taught what sample, what's the right sample, how good to take a sample. Appropriate selection of the test is the most important thing. You can then go by the blue column, which is the usual conventional method, or you can actually cut short the whole process by the innovative rapid PCR test. So, I think except for the 7th point, research and hospital immunology, everything can be done. Everything can be done with a little expertise, little time, and then thought. To the clinicians out there, microbiology is not a shadowy place. Know your lab and interact with them regularly. Order the tests which have good literature support. do appropriate sampling and don't demand to report everything that grows, and develop the culture of cultures. So microbiologists are ID physicians' backbone because 70% of all the medical decisions are based on lab results. It's not a diagnosis made, even if you make a clinical diagnosis, only by proof you know that you're right. So I will summarize and I will stop with that, and if there are any questions I can take. Thank you. So this is for all who want to take IDS and career. These are all open. So recently we had 2 centers opened in Kerala. One for DM infectious disease, that is at Kottayam Medical College, and the second is a fellowship, National Board of Examination, that is FNB. It's Kim's Health to Anand, Kerala. So anyone who wants to take up this case, please pass the message. Thank you. Yep.
Please, one small question on the first slide.
First slide?
No, not, don't go to first slide. Just in first slide when you are saying the importance of gram stain, you mentioned about CSF gram stain. Please share your experience. Pre-culture CSF direct gram stain. What is your frequency of getting positive?
Very.
Right? And
we go by cell count and empirically start.
Right. Thank you. I thought probably
No.
Thank you.
It can be India Inc. anything, sir. Whichever you prefer.
Actually, what sir said and you shared, in microbiology when we are trained, we are specifically taught the heaped up gram stain method for CSF, which improves the detection of the smear being positive. So I think a lot of people forget to do that. Otherwise, the heaped up smear is supposed to be, and in fact, it should not be heat stained as well, because again that washes off the smear. So there are some nitty-gritties to be followed, and it helps them.
Thank you, Dr. Rajalakshmi, for the wonderful insight on what an ID physician looks from the microbiology lab. And I think the accurate diagnosis, rapid turnaround time are the 2 most important things which an ID physician looks from the lab. And vice versa, the microbiologist looks for a very accurate specimen. That is very important also to have a accurate diagnosis. But now, compared to the previous, more and more labs are getting consolidated because of the business interest and economics of scale, and they are getting consolidated and being outsourced. And you have mentioned regarding the advantages and disadvantages of the same also. We have Dr. Avinash also, who is the CEO of Kim's Health. How do you see this, sir?
Profitable?
No, from a clinician's point.
So from a clinician's point, I think what I could say, I'm a radiologist myself, so it's not that I'm coming purely from a management background. So I understand the way we are scaling lab is we have to follow certain examples from radiology. The baseline in the lab, they are very quality conscious. That's the baseline in the lab, which unfortunately is not the baseline in radiology. Radiology is more of operational excellence. Lab is like more of a clinical, I would say quality excellence. What we're trying to do is bridge the gap and bring both towards matching these needs and then take it to the last level. That is business excellence. So we have to start, as radiologists, I look at lab and I see how they are very, very meticulous and pertinent. Whereas in radiology, we are all about, getting the best image, report everything that we see. So I think we need to find that good marriage in that way to work together.
I think 10 years ahead, we will be having very few microbiologists inside the hospital, and they will be with this PACS and this intelligent system of pathology reading and all. They will be placed in a remote place. So communication and personal interaction might get affected.
I think if you manage to sit through the second half after the tea session and listen to me talk on Uberization of diagnostic space, you'll realize how we have been commoditized as radiologists, and you're not far behind. So I guess everyone is having that communication. Unfortunately, we communicate on WhatsApp, and we don't communicate in the true sense, like she says. Pick up the phone. I think my criticism as a radiologist, and I'm standing out in this organization, is I've seen very few laboratory specialists picking up the phone and having arguments. I wish that could be more. And I've seen very few clinicians going to the lab and giving them. it comes much more too easy to radiology. So I guess we need to change that perspective, like you said. Communication is the key before, after. It is not only for asking history. Thank you.
How we practice, no? We don't have an in-house ID program as such, but we have DNB residents. So before my rounds, they visit the microbiology, they get all the alerts. I start my rounds with alert because I'm better informed. It takes another 3 hours for you to authorize and upload. But I can make decision in the morning. I don't have to redo the rounds in the afternoon. So I am 3 hours ahead from the reporting. Even if they don't finalize the report, I know with a susceptible pattern I can decide. So I grab all the reports, they join only with the reports, and then they don't join. Regarding radiology, any radiology that is of interest to us to make decision, we make our residents contract because that's the only way forward. Because we get the results early if they discuss by 4. I don't wait for authorization upload. That is another 3 hours. We're wasting time. So communication is the best way, two-way.
Thank you, Dr. Rajalakshmi. I think we can wind the session.
Thank you.
Thank you, Dr. Rajalakshmi and Dr. Deepak for chairing the session.